Welcome to Adapting Class. Fluid electrolyte IV therapy, very complicated topic. This is something you have to master. This is part 2, challenging 15 questions using NCLEX practice question for our pharmacology test 17. Critical thinking concept. Grab a pen and paper, get ready, write some concept down so that when you see these questions again, you never forget. Let's get it done. First question, NGN star. To test your mind. This is not complicated. Don't run away from it. Stop the video and try to answer it yourself. I've given you everything. It looks difficult, but it's not. It's just the picture presentation. Let's get it done and break it down easily, right? Which prescription should the nurse question? That means one of these prescription we need to question. And nurse is caring for a client admitted for what? Pneumonia. And I give you lab value, NGN star, next generation. Potassium, 3.8. Sodium, 120. BUN, 20. Creatinine, 1.5. Which prescription? You have to question. Bring your critical thinking, test-taking strategy. Make this question very small. Tell yourself, patients being admitted for pneumonia. They're not asking me about pneumonia, but they give me a lab value. Those are the lab value. And I have to question some prescription. What do I see? Like I said, stop the video, write the concept down, answer the question, and then listen to me. This is a learning process. This is a teaching video at the same time using test-taking strategy to break down the question and give you test-taking strategy. Therefore, I see potassium 3.8. What do I think? Sodium 120. What do you think? You got to interpret it, BUN and creatinine. And I've been given this. Do I question digoxin, acetaminophen, 0.45 sodium chloride, or ipotine? I look at it. I said what? Patient creatinine is 1.5 BUN. It may look like he has renal insufficiency. I don't know about ipotine, but if you have a kidney disease, that's why we give it to you, right? So probably because you cannot make erythropoietin, right, in the kidney. So you may need ipotine. Well, let's hold on to that. Acetaminophen, well, there's no contraindication. If you have kidney insufficiency, you should not take NSAID. I see digoxin, but I see that the potassium is normal. Don't pick it because you see digoxin. That doesn't mean it's the right answer. I know a lot of people will pick it, but this is the way you break the question down. 3.8 is fine. Sodium is hyponatremia. What fluid do you use for hyponatremia? Hypertonic fluid, not hypotonic. This patient, you're going to kill them because his sodium is too low. We should question this. You see how the question is broken down? Test-taking strategy. And these are your answer questions. These are you think about it critically. So if you have hyponatremia and you combine hypotonic fluid, then you're going to worsen the situation. Patient is going to get into trouble. Therefore, we should not do that. So number 3 is the right answer. This is also the same thing based on that. A nurse is caring for a client receiving what? 3.5 normal saline. Break down the question, find the buzzword, and figure out what you need to do with the 3.5 normal saline. It's still normal saline greater than 1%. So too much sodium, which nurse intervention is a priority. I got to be sharp. If I'm going to be sharp, then I'm looking for airway, breathing, circulation, things that will affect the patient and can make their condition worse. Then you ask yourself, do I reposition the client every 2 hours? And do I check the IV site for redness or infiltration? Do I encourage the client to drink extra water? Or do I check for what? JVD. Stop the video, answer the question, 10 seconds, and come back and look at what the way I'm going to approach it. But I know you got it. I'm giving you 3.5 normal saline. That's a lot of sodium. If I give you too much sodium, your blood pressure is going to go up. At the same time, 3% is going to pull fluid into the intravascular system. So if you pull fluid into the intravascular system, it go to your lung, it go to your heart, it stay in the intravascular system, you get what? Fluid overloaded. That's what 3% is going to do to you. Therefore, repositioning, do you think is the most important? Do you think looking for redness at the site is important? Do you think let them drink extra water is going to do anything to them? They're already fluid overloaded. Look for signs of fluid overloaded. Lung crackles, JVD, cardiopulmonary collapse. These are the key aspects. Test-taking strategy, critical thinking about this question, NCLEX practice question. So this is the way you should do that. The fluid shift will cause pulmonary edema or cardiovascular collapse. And therefore, JVD is the right answer. Electrolyte and EKG changes, you have to master them. And then it's assessing the client on continuous cardiac monitoring. The EKG traces shows what U wave. You have to know what electrolyte will cause U wave. It's a concept you have to know. This is a straightforward question. If you don't know it, you don't know it. But if you know it, it's good. If you don't, I said concept. Every question, there is a concept. I want you to take a pen and paper and write the concept associated with this. Stop the video, slow it down, and write it down. Which electrolyte abnormality may cause this? What will cause U wave? Then you ask yourself, I have hyponatremia. Does it cause EKG changes? Tell yourself that. Hypokalemia. Hypokalemia. Does it cause EKG changes? Hypomagnesium. Does it cause EKG changes? And hypokalemia. Does it cause EKG changes? I can tell you, hyponatremia alone doesn't do that, in addition to any other thing. Hypokalemia causes what? QT prolongation. Hypomagnesium causes torsade de pontes. Therefore, by elimination, I know U wave has to be caused by hypokalemia. And this is the way I break down questions. I don't rush. I go for the buzzword, and I take care of this. I break down the question into pieces. You should do that. Test-taking strategy, pharmacology practice test. I'm trying to make pharmacology not your enemy anymore. This is the video number 17. You have 17 videos to master pharmacology. You should follow the series, watch them until you can answer every question associated with pharmacology, whether you're in nursing school or you're taking the NCLEX. And then she's assessing the client admitted for what? Buzzword, hypovolemic, hyponatremia. If you don't understand those words, circle them and say, the examiner is telling me something. Hypovolemic, hyponatremic. Why do you put these words there? Which finding should the nurse expect? Then I tell myself, I'm going and figure it out what is hyponatremia and hypovolemic. I know hyponatremia, sodium is low. Hypovolemic, low volume. So you've lost some volume. So you either dehydrated. To be hypovolemic means you are dehydrated. And then to be hyponatremic, you lost a bunch of sodium. This is the thing. So all these buzzwords over there, I can just write that the patient is dehydrated. That's all. Hypovolemic, hyponatremia. He has lost fluid and the sodium is low. Because you can have hyponatremia, hypervolemic. So you can have increased volume, right? And your sodium still will be low. Remember SIDH? Yes, that is hypervolemic and hyponatremia because you have too much fluid diluting your sodium. That's dilutional hyponatremia. This is not dilutional hyponatremia. This is loss of fluid and sodium. Therefore, what do you have to expect? This patient is dehydrated. Would I see a JVD? Think. Would I see bounding pulse? Don't pick the answer because they sound really bad. Orthostatic hypotension. Do you expect that? Bradycardia. Do you expect that? Then you stop the video, then you answer it, and you come back and you listen to me, and I'll tell you, somebody who is hypovolemic, his heart rate is supposed to go up. Somebody who is hypovolemic, his JVD will not be there. The neck veins will be flat. Somebody who is hypovolemic, the pulses will be thready. Therefore, by elimination, I know orthostatic hypotension should be the right answer. I know you got it. I know you picked the right answer because adaptant class is rooting for you. Clients will lose both water and sodium, and therefore will have signs and symptoms of hypertension. Number 5, how are you doing so far? I know you're getting it. This is the same. I'm building up on each question. I'm building up from the previous one. And you can see it's the same thing. Don't run away. Stick around. It gets harder and harder and harder. But at the same time, critical thinking, critical thinking, critical thinking. It doesn't mean you can solve it, but apply a little bit of critical thinking to answer these pharmacology practice tests, IV therapy, fluid, volume, in addition to IV fluid and electrolyte. A client is admitted with what? Hypovolemic dehydration. That's what we talk about, right? So he lost fluid and sodium. So there is no fluid and there's no sodium. The ward does not have what? Plasma expander. You have to know what is plasma expanders. They are not available. So we have dehydrated patient who is hypotensive probably, and we need to give them fluid, but there's no expanders. Which prescription should the nurse anticipate? Normal saline, 0.9, abnormal saline, D5W, or lactate ringer. Go back. I have hypovolemic, so low volume. I have low sodium. That means I've lost fluid and sodium. So I need to replace the sodium. At the same time, I need to replace the fluid. But what is the problem? They wanted to use plasma expander, but there's no plasma expander. What is plasma expander? Anything that will expand the plasma. And one of the most common medication is what? Espan or albumin. Those are the things that stay in the plasma and expand it. In the absence of plasma expanders, you got to use isotonic fluid. That is the concept, and I expect you to write it. In the absence of plasma expander, always use isotonic fluid. And as you can see, there's 2 isotonic fluid there, normal saline and lactate ringer. Abnormal is hypotonic. But D5W is hypotonic if it's infused. If it's on the table, it's different. Therefore, which one would you choose? Why do I give you normal saline and lactate ringer? I can tell you the number 1 resuscitative fluid. If they give you normal saline and lactate ringer, always pick normal saline because it can expand the plasma quickly than that of a lactate ringer. Therefore, 9% normal saline is better than LR in this situation. So we prefer normal saline for initial volume resuscitation in the patient who has what? Hypovolemic dehydration. That's the medication we're going to use. So number 1 is your right answer. And nurse is caring for a client with what? Potassium of 3.3. Think about it. Your potassium is that low. Who is prescribed 30 milliequivalent of IV potassium replacement? We got to replace the potassium. All is fine. But look at the question. Which assessment finding requires the nurse to notify the healthcare provider? Step back. Don't answer the question. Look at it. Say, patient potassium is low. I need to replace the potassium. I did an assessment. Which one should concern me? 1, you have a muscle cramp. Constipation. Urine output, 25 ml in the last hour. Weak peripheral pulses. Okay, these are bad problems. Which one would I choose? There's a concept there. And you know the concept. That's all I want you to go with. Take the buzzword and the concept associated with this question 6 and ask yourself, what is your priority when you want to replace potassium? Potassium is low. Go back to your content, 3.3. I expect constipation. You can have muscle cramps. You may have some weak pulses associated with it. But when I see urine output that low, if I give you potassium and you cannot pee, if I give you potassium and you cannot produce urine, right? This urine is oliguric, right? It's very, very low. And if you can make urine, you're only making 25 ml in the last hour, that means your kidney is not doing well. If I give you potassium, it's going to go up. You can have higher potassium. This is the major concept you got to pick. You should not give anybody potassium if they are not making urine. This patient is not making urine. Therefore, the priority is number 3. And that's the definition of oliguric patient. Therefore, number 3, you should pick it. We are in the middle of it, halfway. What is your score? Question 7. I know you got this. Think about this. This is a question on blood transfusion. It's IV therapy idea I'm trying to get you. A nurse monitors a new graduate nurse who prepares a unit of what? Packed red blood cell for a client. Which observation indicate the new nurse require additional teaching? Selecting white tubing with the inline filter, verifying the informed consent is on the chart, checking the expiration date on the blood unit, and hanging an IV solution of dextrose. What would you think? If you have to give a patient blood, what are the concepts you need to know? Content associated with blood transfusion. I know you got it. Stop the video, put down your answer in the comment. Let me know about it. Say number 7. Number 7, this is what I choose. You know blood transfusion, you need a filter line, right? White tubing, so that you can connect the fluid will be going at the same time in the blood. You know you got to verify consent. You need to check the expiration. But you know glucose is not good. Dextrose should not be infused with what? Blood, because it's going to cause the blood to immobilized. Therefore, that's why you use normal saline. You should not use dextrose solution. It will let the blood rupture because it leaking into the cells. This is a problem, and this is the content I want you to know. Number 4. Number 8, same thing, NGN style. You got it. Don't worry. Don't run away. This is the content. You got it. A nurse is caring for a client who is what? Dehydrated. And he's been vomiting what? And having diarrhea. 2 problems. Therefore, we have excessive vomiting, something from the mouth, and then diarrhea, something from the bottom. So we have severe dehydration. His mucous memory is dry. I'm telling you, patient is dehydrated. Blood pressure is low. They probably is in shock. You can see tachycardia, hypotensive, dehydration, because he's been vomiting for a while. Look at the potassium. It's normal. But sodium is 150. What do you think? BUN is elevated. Creatinine is elevated. What fluid will you give to this patient? Think about it. Dehydration, is having diarrhea, is vomiting. And this is the lab work they give you. Potassium is normal, but sodium is so elevated. It's 150. This is due to the what? Fluid loss. When you lost fluid more than sodium, this is what you have. So we have hypernatremic what? Hypovolemic state. You see, this is the IV therapy questions that sometimes can trap you. Think you got to be able to define it. Patient is what? Dehydrated, right? Hypovolemic state, but his sodium is low. So hypovolemic state where the sodium is low. So dehydrated hypernatremic state. That means patient need fluid. At the same time, we got to correct the what? Hypernatremia. That is the easy way you can think about it. Rewrite it on your own. He said, he's dehydrated, but his sodium is low. Therefore, I got to give him fluid. At the same time, I have to control what? The hypernatremia. Which fluid would do that? If you give them 0.9%, the sodium goes up high. So this is not good. If you give them half normal, you will give them free water, right? That will correct the sodium down. And then this will, the sodium, a little bit of sodium will stay in the system to maintain the blood pressure. If you give them just water, their blood pressure will go down more, even though it's going to correct the even though it's going to correct the hypernatremia. Lactate ringer is not going to correct the sodium that much. So the best answer is number 2. But this is the hardest questions of all. I keep on saying that, but because all the questions require some critical thinking to be able to manage them. Therefore, number 2 is your best answer. This is the explanation that we have hypernatremic state and the patient is what? Hypovolemic. So when abnormal saline will provide those situations, is an hypotonic, it will take care of the hypernatremia and then will help with the hypovolemic. So 2 is the best answer choice. And this is caring for several clients or medical surgical unit. Which client is at risk for developing what? Hypernatremia. There's a mnemonic I'm going to give you that you should never forget. What are the conditions that causes hyperkalemia? Is it what? Kidney injury? Is it spironolactone for heart failure? Is it you have major tissue injury? Do you have low adsorption or you burn? These are conditions that you have to be familiar with. They're going to ask you. These are another way of electrolyte questions they may ask you. If you have kidney injury, your potassium is going to go high. If your urine output is very low, less than 400 in 24 hours. If you're taking spironolactone, it's potassium sparing. You expect potassium to go up. If you break your tissue breakdown, crash injury, you release potassium from the cell. It's going to increase your potassium. Adsorption, if there's no adsorption, potassium goes up. And if you burn yourself, it's the same thing as crash injury. Potassium goes up. So what is the acronym? What is the mnemonic for hyperkalemia? And I call it machine. This is the key for hyperkalemia. Whenever you hear hyperkalemia, think about some medications that can cause that. Spironolactone, ACE inhibitor. Acidosis is a major cause of what? Hyperkalemia. We have cells dying, cellular destruction, hemolysis or hyperadsorption. If you take a bunch of potassium or if your kidney is in trouble, and if you can see, if you take the first letter of each of them, M-A-C-H, all down will spell what? Machine. So hyperkalemia is taken care of by what? Machine. That are the causes. And so all of these answer choices are right to teach you what are the major causes of hyperkalemia. These are the acronym. A nurse is caring for a client receiving IV fluid, right? Getting fluid. During the infusion, the client develops shortness of breath, bad problem, complication, crackles, complication. As you're reading, you're telling yourself, I'm having trouble. Blood pressure is elevated because you expanding the fluid. All of them are fluid overloaded signs. Which action should the nurse take first? What do you think? You give the patient fluid, they are having what? Circulatory overload. What do you think? Do you slow down the infusion? Do you give them diuretic? Do you elevate the head of the bed? Or you obtain seat and chest straight? Do you do that? What do you think? How good is your prioritization? You have to look at the scenario. I'm pretty sure you have seen questions where they said, hey, in this situation, you got to raise the patient head up so that they can breathe. But what? The fluid is still going. We got to stop the poison that is causing the problem. The poison that is causing the problem, you need to slow it down or you stop it. I did not tell you to stop it. The best answer choice is what? Slow it down. If I have to do anything, I'd rather stop it. But there's no stoppage there. Based on the condition, I will slow it down. Raising the head of the bed is not going to solve the problem because the patient is having circulatory overload. The fluid still go into the system. I would rather let them get Let's rate. And therefore, number one is the right answer. So slow it down, but best answer choice is to stop it. This is the build-up of the same question. And next is assessing the client who is receiving IV fluid for dehydration. On assessment, he has what? Crackles, JVD, shortness of breath, and pounding pulse. I'm trying to teach you something. I'm trying to teach you concept that when you give a patient fluid, you should look for circulatory overload. All right. And this is what is happening to the patient. They're going to have signs and symptoms of cardiopulmonary complication. What condition? There's no way this patient is hypovolemic shock. You can't be in shock when you have JVD. That means too much fluid, unless you have cardiogenic shock, but it's not hypovolemic. Circulatory overload, yeah, too much fluid in so fast situation will cause that. Pulmonary embolism, there's nothing in the question that tell you he has pulmonary embolism. I did not tell you he's been resting, his leg is swollen. If I want you to worry about pulmonary embolism, I will have given you signs and symptoms regarding his what? Lower extremities. Choice. Make sure there's enough information in the answer choice that will in the question that will help you. I did not give you a description of his leg or anything like that. Oh, I'm telling you, you're getting fluid. You don't get pulmonary embolism from fluid. Of course, you can get what? Air embolism. But air embolism is going to be different. I will tell you, sudden onset of feeling of doom. Those are the things that are called buzzwords. When you hear that, you know this is air embolism. This patient is not having that, and he's not having heart problem either. These are signs and symptoms related to what? Circulatory overload. And those are the things the nurse should be aware of. A nurse is caring for a client receiving IV antibiotics. The client reports what? Tenderness at the IV site. On assessment, the nurse notes redness along the vein, palpable core, warmth, and swelling. What should the nurse do? These are our buzzwords. Palpable cord is a buzzword. Redness along the vein is a buzzword. Warmth and swelling, these are keywords. You got to put it together and make a diagnosis. What do you think this patient has? Is this phlebitis? Is it infiltration? Is it what? Vesicant infiltration, extravasation? Be the judge. But use the buzzword to make the diagnosis. After that, then you know what to do with the treatment. Do you apply cold compression? Do you what? Restart a new IV on the other hand? Do you slow the infusion down and apply a warm compression? Do you flush the IV with the normal saline? Your content will tell you the palpable core and the redness along, a streak of redness along the vein. This is phlebitis. The best way is to remove the IV, start at another site. That is the key associated with that. Number two, those are the content, buzzwords I want you to know. And this is assessing several clients. Which client is at risk for developing hypermagnesemia? I want you to answer this question and put the comments down and tell me, this is not a hard question. This is not the tricky question. This is a question that requires some content. But my content, I'm going to give you easy way. Stop the video, answer it. Every time they ask you questions about fluid, always find your kidney. Find where your kidney is, because kidney is responsible for taking care of fluid and electrolyte. Therefore, I tell you, a bunch of patients, which one is going to have high what? Magnesium. The only thing that will take away your magnesium is what? Is it your kidney? Is it your diarrhea? Is it loop diuretic or thyroid problem? Thyroid problem has nothing to do with what? Your magnesium. Probably give you diarrhea, but it's not the best answer choice. Loop diuretic will lead to hypo what? Magnesium. Diarrhea will give you that. Kidney is the only way to get rid of what? Your magnesium. Therefore, if you have chronic kidney disease, your magnesium goes up. Number two, your magnesium goes low. 3 go low. 4 probably go low. But the only thing that will increase your magnesium is when your kidney doesn't work. So magnesium is primarily excreted by the kidney. Therefore, if you have impairment, you have a higher magnesium. And this is caring for client on medical surgical unit, right? The nurse recognized that the client is at risk for developing hyperkalemia due to which condition? Which condition will make you develop hyperkalemia? We already seen it. We've seen our machine, the buzzword, the mnemonic to know hyperkalemia. But I change it. I just want to broaden your knowledge so that you don't depend on those isolated things, such that when the NCLEX give you a harder one, it's easy. This is the same thing. I make it harder a little bit, but you can use the same content. Loop diuretic, do they cause hyperkalemia? Metabolic acidosis, does it cause hyperkalemia? If you're on steroid, does it cause hyperkalemia? NG tube, does it cause hyperkalemia? If you have bulimia, does it cause hyperkalemia? What do you think? It's a selected apply. You don't have to pick everything. Pick the one that you're 100% confident. And I know you're going to pick this NG tube. Any patient that has NG tube, the suck out the fluid, you're going to become hypokalemia because of what? Because of the metabolic what? Alkalosis. Therefore, this is not going to do that. If you have too much steroid, your sodium goes up. Definitely your potassium go down. So this is not going to cause your potassium. Bulimia patient, they're going to vomit all the time. They are like NGTV patient. Their potassium is always low. Now you're left with this. Loop diuretic, what would they cause? Hypokalemia, right? Except spironolactone in there, they are no loop diuretic, but they are potassium sparing. Therefore, the only thing that will cause hyperkalemia is what? Metabolic acidosis. How? If you have H plus ion, that is acidosis, your body tries to push the acid inside the cell. In the process, you push potassium outside the cell, and this leads to hyperkalemia. So there's only one answer choice there. This is why I said this question. You don't have to overselect, right? You don't have to overselect. And therefore, metabolic acidosis will lead to hyperkalemia. That is the only answer choice. And the last question, I've given you a clue on this. A nurse is caring for a client 5 days with what? Projectile vomiting. He's been vomiting everything now. Which electrolyte abnormalities should the nurse suspect? So this is a patient, this is the stomach, and when he's vomiting, right, all is coming out is sodium chloride, right, and acid also. So you lose all these things. So his bicarb remain high and become metabolic alkalosis. His sodium is going to go down. Because of metabolic alkalosis, you will lead to what? Potassium is going to go down. Metabolic alkalosis causes hypokalemia. Metabolic acidosis causes hyperkalemia. Therefore, potassium is going to go down. Sodium is going to go down. Because you're vomiting HCl, your chloride also go down. Your body will try to compensate with sodium, but it's not enough to take care of it. Therefore, you have low sodium, low chloride, low potassium, metabolic alkalosis. This is a lab work you have to know. Every time they give you NG tube, they give you patient vomiting. No, that is true. You should expect hypokalemia, hyponatremia, hypochloric, metabolic what? Alkalosis. Your potassium is not going to go up. Your sodium is not going to go up. Your chloride is not going to go up. Your magnesium will go low because you're not eating. And of course, your potassium is going to go low. 15 questions. NCLEX practice question. Pharmacology practice test review. This is fluid, electrolyte, and IV therapy complications associated with it. Thank you for watching. If you like this video, click on the like button and put the notes about what you like over the video. If you have a comment, if you have a specific question, put it down. Thank you for watching and subscribe to Adapt NCLEX for more content like that.